Hello, everyone. My name is Stephanie Johnson, and I'm a community coach with the County Health Rankings and Roadmaps program. Thanks so much for joining us today for this Quality of Care webinar. I'm joined by my colleague, Karen.
Hello, everybody. I will be helping to bring your questions to Stephanie and Dr. Neely's attention and answering questions, sending out some chats throughout the webinar today.
Thanks, Karen. And we're so excited to have Dr. Clare Neely, who is the Chief Medical Officer with the Institute for Clinical Systems Improvement, with us today to talk about integrating behavioral health and primary care. Welcome, Dr. Neely.
Thank you, Stephanie. I'm looking forward to this. It should be an interesting discussion today.
Thank you. So first, we'd like to acknowledge the important relationship we have with the Robert Wood Johnson Foundation. The County Health Rankings and Roadmaps program is a collaboration between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. Next, we want to take a moment to get you oriented to the technology we're using today. The GoToWebinar attendee interface is made up of two parts. On the left, you can see the viewer window where you will see our screen throughout the presentation. And on the right, you can see the control panel. Here is where you'll find handouts for today's session. This is new for some of you who've been with other webinars with us in the past. We're going to have a note-taking handout for you to use throughout the session, and a PDF of our slides, and a list of related links will be shared after the presentation. You can also interact with us through the control panel by using the questions section. Please feel free to ask questions or share your thoughts and experiences with us via the control panel throughout the webinar today, and we'll be sure to leave time for your questions. So this question really guides our webinar today. How can integrating behavioral health and primary care contribute to building a culture of health? As we talk today, we'd love to hear your experiences with integrating behavioral health and primary care. Feel free to use that question chat panel to share your experiences. Tell us what's worked well, what's been challenging, and what have been your lessons learned. Be sure to tell us your community name in your message, and we'll share it with all attendees. And as we move into the real content of the webinar, we'd like you to consider these questions as you listen. Who else do you need to share this information with? What's one idea for action that you're taking from this webinar? And what else do you need to know to take action and use this information? So we're just going to start with a brief program overview to ground you in our discussion in the County Health Rankings and Roadmaps. For those of you who are newer to us, this is going to give you a high-level overview of County Health Rankings and Roadmaps. For those of you who've been on other webinars, this will be review, so thanks for your patience. To learn more, we encourage you to check out one of our Rankings and Roadmaps 101 webinars, and Karen will chat a link out to our most recent recording. So, the County Health Rankings ranks the health of nearly every county in every state. For each county, you'll find two rankings, one for health outcomes and one for health factors. This image shows the relationship between policy, health factors, and health outcomes, and it illustrates why it's important for communities to take a broad definition of health. Many factors impact how well and how long we live. Things like how we commute to work and housing conditions, access to parks, quality of our schools and access to healthy foods, community safety, and even things like our social connectedness all impact our health outcomes. So what does this image tell us? Starting from the bottom, effective local, state, and federal policies and programs can improve a variety of factors that in turn shape the health of communities. And there are many health factors that shape our community's health outcomes. We specifically look at health behaviors, clinical care, social and economic factors, and the physical environment. We measure two types of health outcomes to show how healthy each county is, length of life and quality of life. So today's webinar is going to focus on quality of care, But we're going to hear from Dr. Clare Neely how several other parts of this model come into play when working effectively to integrate behavioral health and primary care. So, Dr. Neely, taking a look at our model, where do you see our work in this model?
I think in the project that we're going to talk about today, there's no question that all of these impacted the care that patients both sought and received. I think your health behaviors, socioeconomic factors played a big role, where people lived, all really impact the quality of care, especially when you're trying to integrate behavioral health and primary care.
So true, and we're just looking forward to hearing your insights about this integration of behavioral health and primary care. So why is this important? Well, despite efforts toward higher quality care, it's estimated that approximately 30% of patients didn't receive the recommended preventive care or treatment in 2009. So it's an important thing to be mindful of, and we're going to take a little closer look at what we measure for quality of care in the county health rankings. So on your screen, you're seeing a part of a county snapshot from Dane County, Wisconsin. That's where we're based. And we're going to take a quick look at clinical care, and then more specifically, 4 measures within clinical care. First, mental health providers. This is the ratio of county population to the number of mental health providers, which includes psychiatrists, psychologists, licensed clinical social workers, counselors, marriage and family therapists, and advanced practice nurses specializing in mental health care. So for this illustration, in Dane County, there is 1 mental health provider for about every 300 people in the county. Nationally, this measure really varies greatly, ranging from 70 county residents to 52,600 county residents per provider. But most counties will fall between 400 and 6,000 people per provider. And the average nationally is about 1,100 people per mental health provider. This measure is actually an access to care measure, but it's related to our quality of care discussion today. And data comes from the Centers for Medicare and Medicaid Services. And then the following measures below are quality of care measures. And this includes preventive hospital stays. This measures the number of hospital stays for conditions that should be receiving care in an outpatient setting per 1,000 Medicare enrollees. We look at diabetic monitoring, which measures the percentage of diabetic Medicare enrollees ages 65 to 75 that receive appropriate monitoring of their chronic condition. And then finally, mammography screening, which measures the percentage of female Medicare enrollees ages 67 to 69 that receive mammography screening. So data from each of these measures comes from the Dartmouth Atlas of Healthcare. And you may have noticed that all of our quality of care measures use Medicare data. And that's because the only national quality of care measures available at the county level are from Medicare. However, most states maintain quality of care records at a hospital or clinic level, and that can provide more complete local quality of care data. So, Dr. Neely, I'm interested if you can share with us a connection that you can make for us regarding these measures and our topic today of integrating behavioral health and primary care.
Certainly, one of the reasons that we here at ICSI got interested in integrating behavioral health into primary care was poor access to mental health providers. And I think your numbers, I would say Dade County is doing better than some places in the country. And yet we know that its access can be very difficult. That was one of our initial reasons for being interested in this. We've also been very interested in reducing total cost of care. And a big part of excess care and excess cost has to do with preventable hospital stays. So again, in the project we're going to talk about, we were looking at that particularly. And again, the patients that I'm going to talk about in this population were folks with depression and also who had chronic disease, including diabetes. So all of these are quite relevant to the kind of work that we were trying to do in the patient population we were working with.
Thank you. Um, let's talk a little bit about what do we do. You know, we understand a little bit more about quality of care data, then what do we do about it? Well, this image on the screen in front of you is the take action cycle, and that's really the how within rankings and roadmaps, and it lays out the process that communities follow to improve health. So not unlike other process improvement models, you want to gather information to assess needs and resources and set priorities so you can focus on what's important, and then find the most effective approaches to address those priorities and get to work on acting on what's important. And of course, evaluating throughout the cycle will help you improve your strategies and ensure that what you're doing is effective. You'll notice that communicate and work together sit outside the cycle because we know that working together and communicating with stakeholders is essential. At the heart is people working together, and we know that solving issues like childhood obesity and poor high school graduation rates or crime and recidivism require the wisdom and resources of everyone in the community. So the Roadmaps to Health Action Center is really your place to find guidance and tools and help communities move along this cycle. And Karen will be sharing links to relevant tools to these guides throughout the webinar today. So how do you begin choosing effective policies and programs? What's the process? Well, we recognize that we're all very busy and it doesn't make sense to reinvent the wheel or waste time implementing strategies that aren't going to be impactful. What Works for Health provides communities with information to help select and implement evidence-informed policies, programs, and systems changes that will improve the variety of factors we know affect health. Strategies are rated based on their evidence of effectiveness, and What Works for Health includes 6 different ratings, ranging from evidence of ineffectiveness to scientifically supported. So from our What Works for Health page, you can click on any focus area of interest. So for today's webinar, we would click on quality of care and discover that there are 29 policies and programs filtered by quality of care. One of the strategies that you'll find here is integrating behavioral health and primary care. And in a moment, we'll hear Dr. Neely share key considerations for effectively integrating behavioral health into primary care. We also want to take a moment to introduce you to the Robert Wood Johnson Foundation Culture of Health Prize. The Culture of Health Prize honors and elevates communities in the United States that are making great strides in their journey toward better health. Here you'll see the 6 criteria that are central to the RWJF Culture of Health Prize. This prize recognizes and celebrates communities that have placed a priority on health and are creating powerful partnerships and deep commitments to make change. Change that will enable all in our diverse society to lead healthier lives now and for generations to come. The prize is awarded annually by the Robert Wood Johnson Foundation, and communities that are awarded the prize work across health factors by defining health broadly. They're strategically focused on policy, systems, and environmental change, and they look out for all, including the most vulnerable in their community. These communities work collaboratively with partners from across the sectors, use resources wisely and creatively, and they measure and share success widely. You can learn more about our 2013 and 2014 prize winners at www.rwjf.org/prize. You can also consider applying for the 2016 RWJF Culture of Health Prize. And to learn more about prize eligibility and criteria, the selection process and key dates, and to apply, go to that website you see on your screen, rwjf.org/prize. The call for applications for the 2016 prize is open, and they're due on November 12th at 3 p.m. Eastern Time. So Karen's going to chat out a link to an archived webinar where you can learn more about applying for the prize. So now I'd like to formally introduce our guest on today's webinar, Dr. Clare Neely. You heard a little bit from her in the beginning of our time today. Dr. Neely is the Institute for Clinical System Improvement's Chief Medical Officer, responsible for leading ICSI's evidence-based medicine work, including guidelines and dissemination and implementation of projects. She's also currently the operations director for COMPASS, care of mental, physical, and substance use syndromes, a $17 million innovation award from the Center for Medicare and Medicaid Innovation. COMPASS is focused on disseminating evidence-based practices to improve the care of people with depression, diabetes, and cardiovascular disease. Welcome, Dr. Neely. Thanks so much for taking the time to be with us today.
Thanks, Stephanie. So I think I'll start with just telling you a little bit more about the COMPASS project. As Stephanie said, it was funded by CMMI, which is one of their first round of innovation awards. And what we did was we took an evidence-based model of collaborative care, a way of integrating primary care and behavioral health that had been well studied. And then we took it to 18 medical groups in 8 different states. And we were not trying to understand if it works. We know it works, but we're trying to understand how to implement it in a wide variety of settings. So we had medical groups that were large integrated systems. We also had small rural clinics that were working on this project. And as Stephanie said, specifically we were looking at complex patients. We were looking at people who had active depression and also had poorly controlled diabetes or poorly controlled cardiovascular disease. And we chose these folks because we know that depression is underdiagnosed in people with diabetes and heart disease. And we know that depression interferes with how well that disease can be managed. Costs are higher, the complications are higher, and there's a higher risk of premature death. So that's the population that we were really focusing on. And also in this project, we were focusing on the whole person. There have been a lot of work done on improving depression, separate from improving diabetes and hypertension and cardiovascular disease. But that's not how people are. People are whole people. So we were looking to focus the behavioral health and the medical around the person. So Stephanie, I think if you want to go on to the next slide.
Yeah, thank you, Dr. Neely. I'm curious if you can share some first steps that communities can take to integrate behavioral health and primary care. We hear a lot from communities around the country, their interest in looking at integration, and what can you share about some first steps communities can take?
I'd certainly encourage people to look at what's worked out there, to understand models and projects and implementation that works. And I think as we put our project together, we had a number of key components, but just 3 of them I just really want to highlight. I think first is the importance of a care manager who's working directly with a patient in a fairly intensive manner. We had care managers who were calling or meeting with people sometimes weekly at the beginning of the project to help them through their depression symptoms or to make behavioral changes. We also had a structured care management program that you can see along the top of the screen here. And I think this was really important. In talking to care managers from other conditions, the care managers who work with really appreciated having a specific way to screen patients, creating a treatment plan with the patient that included medical goals and, as importantly, patient goals. What did they want to accomplish? We worked really hard to help patients learn to take care of themselves. We also used a treat-to-target methodology, which is part of the reason for setting goals, so you could know if you were reaching them or not. And if you didn't reach the goals or patients weren't making progress, what were you going to do to make a change in the treatment plan? So this very kind of thoughtful way about helping patients. The third component that I want to highlight is if you look at the picture in the bottom right, you see a team, and this team was integral to the work we did too. It was made up of the care manager. There was a consulting psychiatrist as part of this team, and also consulting either an internist or family physician, depending on the site. And this team met weekly with the care manager and reviewed all of their patients about whether they were making progress, whether they weren't, trying to think about other ways to help this patient have a better life. And then those recommendations went to help the primary care team take care of patients.
That certainly does, speak to the importance of collaboration and looking at the elements of the triple aim, Dr. Neely. I'm wondering if you can help us sort of just connect the dots a little bit between the coordinated care and the elements of the triple aim that you see on the screen in front of you.
Yeah, this is pretty integral to all the work we do. We're definitely trying to improve health outcomes, depression, diabetes, hypertension control. We're also trying to make it more affordable by decreasing costs. As I said, we were trying to decrease preventable admissions or decrease preventable ED use. We're also trying to improve patient experience. We did satisfaction surveys and interviews with patients to understand what their experience of the system was and how they experienced this change in care. I'm a clinician. I'm also interested in what's sometimes called the fourth part of the triple aim, which is around clinician satisfaction. I think we all know that all of us who work in the system, it can be very difficult, very challenging for clinicians, nurses, physicians, everyone who works in the system. So we were also wanting to improve that for the caregivers.
Great, thank you. Dr. Neely, a question came in that I think is an important one to ask since we were just talking about care managers. Nancy is wondering if the care manager in this model is also the behavioral health consultant.
It depended on the specific site, but by and large, yes. The care managers in our project were mostly RNs, though not exclusively. And they came from different backgrounds. Some of them had come from a behavioral health background into doing this work. Others had come from a medical background. And we did extensive training to help people get their skills up so that they could handle both medical concerns and behavioral health depression concerns.
Great, thanks. Thanks for the question, Nancy.
Yeah.
Let's talk a little bit about how you start building strong linkages between the behavioral health and the medical community. What are some steps that can start building strong linkages?
I think one of the first things to start with is figuring out about depression screening. And it was surprisingly difficult in some communities, I'll be honest. I'll just give you a story. We had one community that we were working with. There were two medical groups essentially caring for a similar patient population in the same county. And one of them was doing very well at screening their patients. They were getting very high screening rates, and they were also finding patients who had symptoms of depression and were getting them into care. The other group had fairly low screening rates, and when they did screen, they weren't finding many people who were depressed. And this seemed unusual to the leadership of that group. And so they went back and had some conversations in their clinics and started to understand that there was some challenges within the clinic. There were people who didn't feel that depression care belonged in primary care. They thought it should be cared for in a separate behavioral health system. There were people who were worried about asking questions of patients to find out about their mood, feeling like they would insult them or somehow cause problems by asking people about their mood. So this is one of the things that led us to go back and think about addressing this whole stigma of depression, and not just for the patients, but for ourselves. And this led to a toolkit that's available on our website that's a kind of a discussion guide to help people start to understand the importance of depression and how it affects people's lives. We also started telling stories because patients, by and large, many of them were appreciative of this. We had stories after story of people saying, "Thank you for asking. Finally, I'm going to get some help." So it was, this whole stigma thing was a challenge that does need to be overcome before I think you can even think about integrating it or building those relationships. The other two guides on here are the Make It Okay campaign, which is again about talking about mental health problems and making it okay to discuss it. And this is not only for caregivers, but for community conversations, which again we found was really helpful in starting to build those linkages by having everybody believe everything is important. The third one that's on here, again, if you haven't looked at the mental health first aid work, I would really encourage you to do so, because one of the things that also came up as we were trying to start this project is the folks in primary care were saying, okay, well, what if somebody tells me they're suicidal? What do I do? And we discovered that having clinics create plans for what you're going to do was very helpful in overcoming some of those barriers that primary care felt was between them and behavioral health. So instead of just saying patient has a suicidal thoughts, instead of just hanging up and telling them to call 911, actually working with them and making those connections was an exercise in itself that helped build some of those community connections.
So important, Dr. Neely, and I appreciate the story that you shared as well. I know a lot of our attendees are interested in, what's happening in other communities, and sharing those stories is so relevant and important. I just also want to add that Karen is chatting out the links for the 3 different tools that Dr. Neely referenced: addressing the stigma, making it okay, and the mental health first aid. So you look for those in your chat links. Talk to us a little bit about partnerships that need to be in place to sort of help facilitate this integration. I know there's probably some information systems things, but what other kinds of partnerships really need to be in place?
Yeah, there certainly are information issues about sharing records and HIPAA requirements and all of that. I think, too, we have other structural barriers between primary care and behavioral health or mental health. Many times these are carve-out programs, so the systems may be functionally separate. And we did run into that with our project, too, because many of the medical groups we worked with were small and did not have a behavioral health division or didn't have any psychiatrists on staff. And so had to start building that relationship because we needed a psychiatrist working with the care manager and the internist or family physician on our consultation team to help manage patients and make recommendations. So the requirement of the program did cause people to go out and start talking to the behavioral health providers in their community to find someone to directly partner with this project. I think we also found that as patients were in the program, they also had mental health providers in the community that needed to be communicated with, because we're making a care plan for the patients and we wanted everybody to participate and help forward the plan. This was difficult sometimes, easy other times. I think these two, the behavioral health and the medical community, sometimes feel like we're so separate that we can't talk to each other. So we had care managers and psychiatrists being very creative in ways they might go out and talk to some of these other providers. We had patients also get involved where they would want this connection to happen. So we had patients who would take their care plan that they got from their care manager and take it with them to their psychiatry appointment and said, hey, this folks were making these kind of recommendations and they're wondering about changing my medication or whether I should try this. What do you think? Write it down for me and I'll take it back. So it was a lot of interesting kind of ways to force the system to work together by patients.
I think that's beautiful, and really encouraging patients and their caregivers to be advocates in their care plan and, truly an engaged partner. I think that's awesome. Talk a little bit about the challenge of comorbidities. So you had mentioned earlier, the depression and diabetes and cardiovascular disease, but also this, the social complexities that are in many of our lives. Can you talk about the challenge of managing that and the balance?
Yeah, absolutely. I think when we started the project, we didn't understand this in the depth that it showed up. We had, as we were trying to recruit patients into the program and invite them in, we ran into a lot of patients who, for one reason or another, were divorced from their healthcare system. And this frequently had to do with social, environmental issues. We had one group that kind of kept track of these social determinants of health that were they thought were interfering with patients getting the care that they needed. And the kind of things that you would expect showed up: homelessness, difficulty with money, no caregiver at home, trouble with the law, changing address, all kinds of things showed up as major barriers in ways that we didn't fully appreciate when we started. And probably about a year into the project, we started adding social workers to the consultant team. I think, like I say, we started out with a couple of physicians and the care manager, but pretty quickly people understood that these social determinants and how to help people with the other parts of their lives were so important that we needed to work with that too. So as I say, social workers became key on many of the teams. And again, I point you to a couple of resources here that might be helpful. If you're not familiar with the work that's being done by Victor Montori at Mayo about minimally disruptive medicine, I'd point you to his website. I think the name of this is a little intimidating, but essentially what they're talking about is how do we as caregivers in the medical system work with patients to make what we're asking them to do fit with the rest of their lives. If we're asking people to take medicine 3 times a day, can they make that work? If they're needing to come to a lot of appointments to manage their care, can they do that without losing their job? So really figuring out how we work, again, looking at the whole person to help them have better health and better wellness. The other resource I would point you to is about trauma-informed interventions. I think this is becoming a better understood field, and people who have, well, I'm a pediatrician, so I probably know most about it in kids, but kids who have suffered problems in childhood, that definitely impacts how they can make attachments and make good decisions as they get older. And clearly that is in some ways overrepresented in people who are getting poor care. So you can't really separate people's medical issues from their social situation.
Certainly not. And as a former medical social worker, I thank you for the plug. And, you know, it sort of brings me back to those days of really working hard to coordinate what patients and families need as part of their overall care plan, and sort of helping to overcome and problem solve some of the challenges and the barriers. I was also just thinking of a note about the concept of health literacy, and I wondered how much of that awareness of health literacy sort of went into your work and the work that the COMPASS program and model is about.
Yes, that was part of our foundational training for all of the care managers, because that is very important, and teaching some techniques such as Teach Back that folks are familiar with to assure that patients understand it. It's also important to remember that folks with depression have more difficulty remembering, understanding, making decisions. So again, working with that population takes some extra care and some extra work.
Thank you. Very important to remember. Dr. Neely, can you speak at all to the integration of, and I feel like I'm using that word over and over again, but I'm thinking about the work that nonprofit hospitals are doing around their community health needs assessment, and looking at this as a potential strategy that could align with their community benefit programs. How are you able to speak to that at all?
Yeah, I think it's really important work. Another part of some understanding we developed with this project, I could talk about this project for hours, Stephanie, we've learned a great deal, but part of it was that many medical clinics don't fully understand their patient population. Medical clinics are designed to take care of people when they come with a problem or when they come for screening or wellness checks, but it's when they contact the system. And a lot of, the work that you do, the work that you're talking about that hospitals are doing, is helping to understand the community out there that may not be contacting the healthcare system, but still needs some support from the system. So this kind of understanding, I think, is critical. And in fact, many of our clinics had to start developing this understanding to be able to reach out to patients and invite them into this care model so they could get the care that they needed and deserved.
Thank you. Thanks so much. What are some other areas of consideration that those attendees who are with us today and those who might be listening to this in the future, what are some areas of consideration that our audience members should be thinking about as they're considering integrating behavioral health and primary care?
Yeah, I think first thing is to think about a target population that you can start out with. Our project was working with very complex patients with a fair amount of support, and that may not be the place for everybody to start, but pick a population that gives you something manageable to think about. I'd also add here that screening for depression is a recommendation that is currently in draft form from the U.S. Preventative Service Task Force. So I'm expecting that will be coming out soon, that they will be making recommendations for more universal depression screening in adults. So it might be something to start thinking about how you get ready for that. Another thing is thinking in particular about depression, but other mental illnesses too do affect and complicate self-management. And that's something to remember. Many care management programs, as we've looked at them, are designed for people who are managing pretty well. And yet folks with depression have much more difficulty attending appointments, remembering to come to their appointment, remembering to take their medication. And so that's something you have to think about. You have to figure out how you're going to work with folks over a longer term when you're working with behavioral and mental health conditions. This is not keep them in your program for 3 months and they're fine and you don't ever have to see them again. So again, being in it for a longer haul, I think, is a consideration. I mentioned it before, but I think I can't overemphasize the importance of setting goals and setting specific goals. We had patients, with their primary care physician, we were setting specific goals. What is the right hemoglobin A1C for this patient? What's the right blood pressure level for this patient? And certainly with PHQ-9, which is what we were using for following depression. And then the patient goals. What does the patient want to accomplish? Do they want to go on a trip? Do they want to be able to visit somebody or have a steady job? So those are real important, and making them specific so you can track progress. And I'd say this is psychologically important for the patient and also for the care managers to be able to see that in working with these sometimes very complex folks with a lot of social problems, to see that you're making progress is really important. Another thing that I haven't mentioned to this point but is a really important piece too is some kind of electronic tool that you can use to track patients. Most EHRs, you can build a registry. We had a particular registry we were using for this project that had a lot of the tools built in it for the care managers to use. It's important to be able to keep track of patients' progress, to keep track of patients, because again, as I said earlier, mostly our system is geared to take care of patients when they come, and we don't have good systems to reach back out to patients when they don't come as they're expected. So having a tool that allows you to monitor the population in that way is very good. And then I think it's really focusing on working as a team, the primary care and behavioral health providers in the community, providers in your clinic, come together and work as a team with common goals determined by the patient to really help things move forward. I've mentioned too that on this page is the Compass Intervention Guide. We did put together a guide for implementing this particular project, but it's also full of a lot of tools that were built or that we link to from other people's work about integrating mostly depression care into primary care for this thing.
Great, and I think if she hasn't already, Karen's going to be chatting out the link for that intervention guide so that you can easily access it. A question that came through from one of our attendees sort of speaks to kind of a billing consideration, and I'm wondering if you can help answer this question from Mavis. She's wondering about billing mechanisms for the model. So, for example, capitation in primary care versus fee-for-service and behavioral health. How do you reconcile those different payment and reimbursement systems?
Well, Mavis is asking a really good question. It's got really complex answers that vary. I think there are certainly payments currently for care manager fees and for care management, I mean. And as we looked at it and ran some modeling, that just doesn't appear to pay for all of these kind of programs when you're dealing with a complex patient population like this. So as part of our project, we're also sending some recommendations to CMS around other payment models. But they're the kind of things that you would suggest, some kind of risk sharing. We have one of our partners in this project who became an ACO during this, and so then felt that that was, with an ACO contract, they could easily implement this model and make it financially viable. But I think we're in that midst of payment reform right now, that everybody's in a slightly different place about what they might be able to do here.
Sure, thank you, and thanks Mavis for your question. We are going to start moving into your questions. There have been some really great questions coming through the question box, and I also want to put in a little plug for you to, if you can, stay with us after the formal webinar has finished for an after-class discussion. And I will show you some instructions in the slides coming up, but just wanted you to know that we'll be keeping the webinar open for about 15 minutes after we've wrapped up, and just we'll continue to take questions as you have them for us. So I'm going to look over to Karen and see if there are some questions that she's flagged for Dr. Neely.
Great, thank you so much, Stephanie. So we had a question about, kind of a technical question about whether you use the DSM-4 or 5 ICD-9 codes to identify behavioral health patients. So how are you identifying behavioral health patients, I think, is a broader way to state that question.
Right, and for this project we were working primarily with depression. There were a few groups who were also doing bipolar, and we were using the DSM diagnostic criteria. We were screening with PHQ-9, which sounds like this question knows is a screening test, not a diagnostic test. And then there will be an interview with the primary care physician or other person to make a determination about whether the patient truly had depression or not. And then we did use the PHQ-9 to follow treatment.
Great, thank you so much. Question about the role of community health workers. So how do you see the role of community health workers in assisting in the integration of care?
I think they can have an important place. We did have a couple of sites who had, or during the project, developed community health workers, community health worker project, and a couple of them, one place they were doing home visits, which again was important. We had some patients who, for a variety of reasons, either medical or behavioral health, didn't like to leave home, and so we had some home visits, and you can learn a lot from home visits too, and the community health workers did that. We also had a community that was working with community paramedics, if people are familiar with that kind of program, where paramedics were going out and doing, started out doing post-hospital visits, but then were also doing visits to patients when they either were not attending the clinic or not answering care manager phone calls as expected, or when things just weren't going well and we needed some more information. So it's part of that whole constellation that you can put around patients and communities to help folks get better.
Thanks so much, Claire. It's Stephanie again. Can you tell us about the impact or the result that integrating behavioral health and primary care has had on specialty mental health clinics? So Nancy's wondering, has that increased the capacity of mental health clinics?
I don't know that we have good data on that, but I can tell you anecdotal stories that I heard from psychiatrists in the community on this. A couple of the psychiatrists, this has been a 3-year project and we're just winding down, and talking to some of the psychiatrists in the last few months, they said they were starting to get more complicated patients from their primary care colleagues, meaning that primary care was starting to take care of depression, in some cases bipolar disease, and making a lot of medication adjustments before they would send them to psychiatry, or the more complex patients were getting to psychiatry. And they were appreciating that because the more complicated patients are the ones that they need to be seeing to best use their skill set. So whether that is a universal finding, I don't know, but certainly people were seeing that in some places. So I think that could only improve access. And I mean, that is part of what we were trying to do, because a psychiatrist in the sitting in our consultation teams, most of those teams met for about 1.5 hours or 2 hours a week. And they would discuss anywhere from 40 to 60 patients during that time. So a psychiatrist was able to give a lot of input into the care of a lot of patients without having to see them. So we would expect that would improve access.
That certainly makes sense. There's another question that I think kind of tags along a little bit with this concept. Lourdes is asking what the differences and challenges are between integrating behavioral health into primary care and primary care into behavioral health services. So kind of that other direction. And can you comment on that?
A little bit, because we've been interested in that here at Institute for Clinical Systems Improvement too, because we know that people with mental illness die significantly earlier than people who don't have it. In some studies, I think as much as 20 years, 25 years decreased life expectancy. So we're really trying to figure out how we might do that. And here in Minnesota, we're working on creating behavioral health homes as a way to get some of that primary care, some of the screening services, some medical care delivered in mental health settings. So stay tuned. Maybe Lourdes has been doing that in their area. But I think there's definitely a need, and I think there's growing interest in it.
Okay, thank you. I'm going to look over to Karen.
So this is a sort of a logistical question, but you talked about doing some depression screening. Do you know, in your sites, were people using paper, just paper and pen, or were they using tablets? Was there something that was more automated in a system? What did that look like, and how did that play out in your communities?
I think all of those things you listed were used. A lot of times people would start out with a paper tool. I mean, as an implementer, I think that's a good way to start, because then you can figure out what your work processes need to be and what kind of electronic tools might work. But we had a lot of paper screening. We had some folks who were using an iPad where people were filling it out in the exam room, and then that linked into their EHR. In other settings, the care managers or the rooming staff would ask the questions. We had people who were screened over the phone. Well, I take that back, not screened, but had follow-up PHQ-9s done over the phone, and that would be read to them. So all of those ways it can be used. I would say it's easiest if you have an EHR, it just pops right into, but not everybody has that.
That is true, especially in some of the smaller rural communities where there's just isolated, they're more isolated and not connected maybe to a broader health system.
To Stephanie's point, there's another question about how you've accomplished, how this has been accomplished, and what kind of workforce issues you dealt with in rural areas, from finding staffing to getting people to do that integration in a rural community. Can you just talk a little bit about what this model looks like in rural communities? I guess I'll make it more broad.
Yeah, we did have a number of rural communities as part of this project, and honestly I didn't see it as much different as far as how they put it together, and in fact I think sometimes in small communities people see these problems in a way that in urban settings you don't notice it on a day-to-day basis. We didn't have any difficulty finding people who are interested in doing this kind of care management work. A lot of nurses really enjoy this kind of work, though it's not for everybody, I'll admit that, but we didn't have a difficulty finding folks. I think one challenge in small communities is it's challenging to benefit. Everybody knows everybody. And so sometimes that can seem to be a barrier where, okay, I'm going to ask you these questions about how you're feeling and whether you've thought about committing suicide, and then I'm going to see you next week at church. How's that going to be? But it turns out it's not really a problem. In Minnesota, we had done a project that was really around asking people about risky drinking. And I run into this barrier in a small community. So we did community surveys and had community conversations about it. And patients believed that their healthcare system should be asking this and that they wanted them to ask. And so we found that same kind of experience reflected in the Compass sites too.
Thank you. Thank you. This is Stephanie again. We have a question for Ellie, from Ellie, that is looking at, I guess, how you are reimbursed for the patient visit. So the context of her question is the social worker and behavioral health professional who have a touch point with the patient, and then the team meeting that happens, kind of that case or care consultation meeting. How are those costs absorbed? And I guess she's looking for some advice, since that reimbursement for a patient visit is considered fixed. How do you account for the consultation time by the other professionals?
A really good question, and again, it kind of depends on how your contracts might be, because certainly if you have some risk contracting, you can think about how you might put this together. This was a grant that was funded by the CMMI, so there was partial funding available to the sites to help them implement and get this project started. And people had to find ways to compensate the physicians. Most people figured out an hourly rate to pay the two physicians for their 2 hours or hour and a half to 2 hours a week, and then used the care management billing codes to the max, which brought them probably paid for about half to 3/4 of the care management time for this. As I say, as people are moving forward with this, they're really putting it into patient-centered medical home work and the financial reimbursement for that, which editorial I'll say is too low too, and also into ACO kind of structures or other risk management. It's a problem right now. We need to change our payment system so that this kind of care that we know works can be adequately compensated for.
You're speaking about payment reform.
Yeah. I am speaking about payment reform, and that's probably another webinar, but
I think so.
But I mean, CMS has signaled that they're making some changes, so I'm hopeful that we can finally make a difference here.
Okay. We're going to move along to finish out the formal part of the webinar. Again, want to acknowledge the important support that we receive from the Robert Wood Johnson Foundation. I'm also going to just say one more time, we're going to have a after-class discussion, so if there are more questions, please send them through. I'm going to give you some instructions in just a moment on the after-class discussion. But also wanted to let folks know that thanks to the Robert Wood Johnson Foundation, we have 11 community coaches. Some of us are based in Madison, others are regionally based around the country, and our assistance is available at no cost to you. Community coaches provide community leaders with direct support that helps to strengthen their capacity to advance health improvement efforts in communities. And our coaches use that county health rankings model. We use the Take Action Center and the Robert Wood Johnson Foundation Culture of Health prize criteria as frames for our guidance. What works for health, that database of evidence-informed strategies, and the Action Center content are practical tools that community members and coaches use to help move from planning to action. You'll find these orange boxes, that orange box you see on your screen, throughout the Action Center, inviting you to contact us for personalized and free help. This is one of the best and easiest ways to connect with one of our coaches. So please don't hesitate to reach out to us if you need assistance with a tool or a question or figuring out the next step in your process. We want to let you know that we have an upcoming webinar on September 29th called Start with the End in Mind, Using Results-Based Accountability. All of our webinars are archived. In this particular webinar on the 29th of September, you're going to hear from Santa Cruz, California. They're a 2013 RWJF Culture of Health Prize winner, and they're using outcome-based decision-making in their community health improvement efforts. Check back frequently. We always are adding new webinars and would love to have you join us. Also, hope you stay connected with us by using social media to stay in touch and communicate about County Health Rankings and Roadmaps programs. So you can follow us on Twitter and like us on Facebook, sign up for our e-newsletter. And want to also acknowledge that our program is the result of the contributions of many, many partners, including those you see listed here. At the beginning of the webinar, we introduced this guiding question to you, and we hope that this discussion has generated some new ideas and thoughts about how you can engage vulnerable populations to build a culture of health. We thank you so much for your questions and being with us today, and want to show you now how you can join us for a brief after-class discussion. So we're going to experiment a little bit. If you would like to speak with us and ask your question, you'll need to switch to the telephone using your audio section of the control panel. So you see the arrow there has now highlighted the dot next to telephone, and you'll find a telephone number and access code, as well as a unique audio PIN. That audio PIN allows us to unmute you during the discussion. Otherwise, you can communicate with us through that question or comment box. You could raise your hand if you'd like us to call on you, but I think for now we'll just give folks a few moments to transition over to the telephone if they would like to continue to join us after class. And again, thank you so much, Dr. Neely, for your insights, your experience, your stories. It's really been a delight and pleasure to have you with us on today's webinar.
It's been my pleasure, Stephanie. Thank you for inviting me.
You're welcome. I know we have a few questions that have come through the chat box, so I'm just going to take a peek at that first. And one question is centered around faith communities, and to what extent has the project that you referenced, the Compass Project, used faith-based as a possible partner? So, for example, using churches, faith communities, either as medical home or to help support the project using care management integrated approaches.
I can think of a couple of things that were done in a couple of different states. In one of them, one of the medical groups already had a relationship with a faith-based community that did a lot of work in the African American community around making diabetes better. And this is a group that had a community worker, and they met at the church. And the care manager, who was part of the Compass program, went out and met with them several times. They did some depression screening at that site too to see if there were some challenges there. And then the worker, actually it's a church member who led that group, became pretty involved in helping patients. Again, if the patient wanted to share their care plan with her, they did, and then she became involved in helping implement the care plan too. And in another setting, one of our hospitals had originally been a hospital that was run by one of nuns, and I can't remember which order they were, but they had recently sold the hospital, but were still involved in healthcare, and used some of the money that they had when they sold the hospital to buy a mobile bus that then they were going out into underserved communities to do health screening and provide some health services. And they became involved in this Compass project too to help patients both link into the care management program and then also be a link back from the care manager sometimes to the patient or to take things out into the community. So again, it's finding other ways that the community can help surround folks who need help.
Thank you so much. That's such a creative and innovative idea, probably not unlike what many of the sisters did years ago, you know, when healthcare was maybe not as complex and had the layers of complexity as it does now, but going sort of door to door and providing.
It's still very useful, yes.
Yeah, absolutely. So I'm noticing on my attendee panel that several of you have switched over to the phone icon. I just highlighted on your screen where you can raise your hand if you have a question that you'd like to ask Dr. Neely, and when you do that, I can unmute you. For now, I'm just sort of quickly scanning. Don't be shy. We're going to give this a whirl.
And just a reminder that you can continue to enter questions through the question and chat box. So we'll be continuing to monitor those questions. And if you've switched to the telephone, be sure that you enter that unique audio pin that I think is still up on the screen. You can see where that unique audio pin is, so that we can unmute you if you want to chat with us. We have a question about handling resistance from primary care providers who were concerned that there was not enough time in their day to implement this model. Can you talk a little bit about how you eased those concerns or worked through those concerns and those challenges with some of the primary care providers that you worked with?
Yeah, and it was a challenge. I mean, here's somebody else that's now on your team helping you care for your patients, and then there's this consultation team that's making recommendations that you have to deal with them. And we addressed that directly. I mean, we met with primary care physicians and talked to them about what we were trying to do, and that the goal here was to support them in caring for their patients, that we were really trying to ease the burden, not add to the burden. So as different sites worked on this, that was one of the things they really watched and talked to their primary care staff to make sure that we weren't doing something that was making more work. Another thing that we did is with the physicians who perhaps were more resistant to this whole idea, we would ask them, give us one patient. Give us your tough one, that person that when she's on your schedule, you just lay down your head and feel bad and want to go home. Everybody's got some of those patients that they just are stuck with. And asked to refer one of those patients to the program and see what could happen. And of course, the program's not 100% successful with everybody. Not everybody does this work for. But we had enough successes that then we could go back and the care managers could go back to the physician and say, here's what I found. For example, we had one patient that the physician knew had depression but just couldn't do anything with the treatment. Hemoglobin A1C had always been 12 or higher, which is extremely high. Didn't come in for appointments, would not take their insulin. And we got this patient referred, and the care manager, after spending a couple hours over a couple weeks' time, as she developed some rapport with the patient, she discovered the patient had agoraphobia, and the patient couldn't read. So these were two things that she went back and talked to the primary care physician about, and he didn't know either one of these. And this was a physician that I met several times, and I would go to him. He was a great doc. And yet the patient had never shared these things, and that made all the difference in the world once this was understood, that these things were really interfering with patient care. And there's any number of those stories that happen. Physicians just don't have enough time to talk a long time with patients. We can go back to the reimbursement system as how that's a challenge. And also sometimes patients are embarrassed to tell their physician that. I certainly run into that in my own practice where my receptionist would know that somebody had lost their job, but they didn't tell me. Or my receptionist would know that the patient couldn't read or didn't understand the directions I gave them, but they were embarrassed to tell me that they didn't understand. And so once you start to understand how, or once the physicians could start to understand how care managers could make their job easier or help uncover information that would then help the patient to be able to move forward, the resistance would drop.
Dr. Neely, that's a really great segue into another question. Thank you for that story. This is sort of a two-part question. Well, it is a two-part question. Stephanie had shared with us that that in her community, the doctors have been very receptive to having social workers available to patients, but a challenge has been convincing or helping the patients feel comfortable talking with a social worker and understanding that that could be a benefit to them. So any thoughts that you have on that challenge? Stephanie also had a more specific question in this whole topic on billing. You mentioned using some care management codes. Any other detail that you can provide about which kinds of care management codes you've been able to use or you've had some success in using would also be helpful. So either, if you want to tackle both of those.
To the technical question first, I personally can't keep codes in my head. We have written a report about that we're sending to CMS that should be published on the ICSI website soon. It's not quite complete, but I expect by the end of the month that will be on there on our website, and it talks about the specific care management codes that can be used for this. So I'm going to defer that question, but information is there. I think the question about getting patients to interact with social workers, I don't know that it's any different than getting patients to build a trusting relationship with anybody in our healthcare system. And one of the things that we spent a lot of time with the care managers in our program on was learning motivational interviewing. And I'm sure many of the people in the call are familiar with that. It's a way of interacting with patients not only to help them find their motivation for doing things, but it's a very respectful way of understanding what's going on with somebody else. And this was part of our foundational training and then became ongoing training at many of the sites as people found this helpful. And so I would advocate for that kind of communications training for all of us who are really trying to build a trusting relationship and a therapeutic relationship with some of these challenging patients. And actually one of our trainers was a social worker, so I know this is very familiar to the social workers that are listening.
Great, thank you so much. We've had a couple of questions about how does this relate, or how do you think about this integration in dealing with children's behavioral health, or with what can children's behavioral health care providers do to position themselves for this integration? And I'm not sure that your project got into children's, but if you have any insights or any thoughts that you think might be transferable there, that might be helpful for folks.
Yeah, yes, we were dealing with adults, so 18 and older, but I'm a pediatrician, so I have opinions about this. But and there are some projects around the country where this same model of care, this collaborative care management, is being done for childhood depression and some other childhood disorders. There are some complications with childhood mental health that can sometimes be a little bit more difficult. A developing brain and a rapidly changing cognitive levels can sometimes make things more complex. And yet I've seen it work for depression in childhood. I've seen it work for some other disruptive behaviors, things like ADHD, Asperger's, where there's been a good partnership between behavioral health specialists, psychiatrists, and primary care to help to provide more of the care for these children and families in primary care. And my experience too with working with families is that's what they prefer. They would really rather be working with their pediatrician or family physician that they know well to deal with some of these very challenging issues with their children.
Great, thank you so much for those insights. I think that we have time for one, maybe two more questions. We'll start with this one. How have you been evaluating, or what recommendations would you have on how to best evaluate this integration to show the impact of this work?
Yeah, well, we're doing kind of a lot of evaluation, but I think for basically, be sure you're setting your goals and then tracking movement toward those goals. Certainly the medical goals are easier, they're numerical, but also there's methods for deciding has a patient reached their patient-determined goals and whether you're making progress on that. I think there's also some goals, some measures and evaluation about how well the major components of the program are being implemented. Part of this kind of care is really having close contact with patients and having frequent follow-up. So some way of assuring that that's happening. There's also importance about discussing patients who aren't getting better. And so how do you assure and follow that that's continuing to happen, that you're making treatment changes, either intensification or changing treatment, if people aren't making progress toward their goals. So thinking about not only the outcomes, but also some of these process goals that are very important to the integrity of this kind of program. And those can, I mean, they don't have to be complicated to set those up, but I think they're important to do both of those kind of measures, especially as you're trying to improve a system. We were also doing measures around trying to decrease preventable emergency department events and hospitalizations, and so I'd encourage people to think about that too. That's a little more difficult. Not everybody can get that information easily about when their patient went to the hospital or went to the emergency department, but tracking that kind of work too, to see what's driving it, why are they going, and what kind of intervention might you do to decrease that.
Thanks, Dr. Neely. I think we have time for just this one last question, and I think this is a nice way to wrap up a really great discussion today, and it brings it back to that patient perspective and thinking about what is it that makes some of the current models not work for patients, and how is this idea of integration, how does that better serve the patients and bringing it back to their perspective?
I think over the last number of years, as healthcare has become more specialized, we've developed the program that works for us, the healthcare providers, to understand if you have this, you go there, if you have that, you go there. And that just doesn't make any sense from a patient point of view a lot of times. They really appreciate, they're a whole human being, and your mental health, your spiritual health, your physical health are not separated from the patient point of view. So we've really found that as we have had this approach, patients have really appreciated it. And also patients have appreciated having a single team that's providing a lot of care for them. Well, we had care managers who were working very hard with the patients and spending a lot of time with them. It was really presented and really was part of their primary care physician or nurse practitioner, whoever their primary care provider was. It was part of that team that was caring for them. And this was an extension of that. And so again, it seemed, and we wanted it to be unified for patients. It makes it easier, and it decreases some of the coordination, and we ask patients to do a lot of work sometimes, just in managing their health care. We're the experts in how to do that, and a lot of that we should manage and let them figure out how things fit with the rest of their life to meet their wellness goals.
Beautifully stated, and very, I think it's a very good reminder of, the patient and family being at the center of care. And I want to thank you again for your time and your comments and expertise, for staying with us in the after-class discussion. This has been so enlightening, and I know that it will be really helpful to those attendees who are looking at integrating this model in their community. So thank you so much again, Dr. Neely, and thank you attendees who have stayed on with us in this after class session. We look forward to seeing you in future webinars.
Thank you, Stephanie.